Good afternoon, everyone. I would like to thank Jill Morgan and OncoAlert Network for the invitation and the opportunity to present the result of our study entitled Assisted Reproductive Technology in Young BRCA 1 and 2 carriers with a pregnancy after breast cancer. As we know, in the recent years, there has been increasing evidence of the safety of ART before or after cancer treatment in patients with a history of breast cancer. However, the evidence of the use and safety of ART in breast cancer patients with the germline BRCA1 and 2 pathogenic variant is very limited. The previous report of the BRCA1 and 2 breast cancer young collaboration included only 22 women with an ART pregnancy after breast cancer. However, addressing the safety of ART is critical for all young patients who are unable to conceive spontaneously after breast cancer treatment and who might need to rely on ART to achieve pregnancy. So our study aimed to answer the question, is it safe for BRCA1 and 2 carriers to use ART to achieve pregnancy? To assess the safety of ART in BRCA carriers, we conducted a retrospective international hospital-based observational study of the BRCA breast cancer collaboration cohort, which included young BRCA1 and 2 carriers with a pregnancy after prior breast cancer diagnosis between 2000 and 2020. The total number of women included in our study was 543. Of 543 BRCA1 and 2 carriers who conceived after breast cancer, 436 conceived spontaneously, representing the no ART group, and 107 conceived with ART. We considered ART procedures, the ovarian stimulation and cryopreservation of oocyte or embryo at the diagnosis, which was performed in 42.1% of the women, the ovarian stimulation and IVF or ICSI or ovulation induction after breast cancer treatment, which was performed by 30.8% of the participants, and the oocyte donation, which was performed by 90.6% of the patients. 7.5% of the patients had missing ART type and were excluded from the survival analysis. So what were the results? The results showed that compared to patients in the no ART group, those in the ART group were older at the time of conception, had more frequently hormone receptor positive breast cancer, and a longer median time from cancer diagnosis to conception. Most of the patients in both ART and no ART group received chemotherapy, 93.5% in the ART group and 92.9% in the no ART group. Regarding the reproductive outcomes, overall 81.6% of the patients in the ART group and 87.0% of those in the no ART group did not report pregnancy complication. However, patients in the ART group had numerically more miscarriage and fewer induced abortion than those in the no ART group. At a median follow-up time of 5.2 years after conception, there was no apparent adverse effect of ART on disease-free survival, with an adjusted hazard ratio of 0.2, which was not statistically significant. So in conclusion, based on our result in young BRCA1 and 2 carriers with a pregnancy after breast cancer, the use of ART does not appear to be associated with an increased risk of disease-free survival events or adverse pregnancy outcomes. And given the interest of many women in having their own biological child, and for some of them in avoiding the transmission of the BRCA1 and 2 pathogenic variant, by pre-implantation genetic testing, our results complete the oncofertility counseling for these women with further essential information.